Hello everybody. So let's start to talk about immediate implants. We live in an era where everything is fast and dentistry too. So our patient asks us for a very fast and high-speed treatment with the immediate provisionalization, and very often they ask us aesthetics. In what way we can create aesthetics for our patient using immediate implants? We have to deal with our tissues. We have to preserve or to rebuild the bone if it's damaged. Then we have to deal with soft tissues. What we can do in immediate implants is to guide nature to obtain the desired healing of soft tissues. For last, we have to use the prosthesis. We can use our provisionalization to help tissue to heal. And then we have to copy and paste and mask in the context to obtain the desired result and to obtain aesthetics. And what about the literature? Christoph Hammerly in 2004 defined the type 1 implant as a immediate, so an implant put it at the same time of tooth extraction. Other authors studied the survival or the success of immediate implants. Lang and co-workers in 2012, in a systematic review on the survival of immediate implants, identified a percentage of success of 98%. What is the aim of this therapy? Reduce the time of rehabilitation. Is this therapy able to make us obtain the same long-term aesthetical result as can do conventional implant therapy? Is the aim of this therapy to avoid or to reduce bone resorption? This could be really important, especially in some areas where the facial bone is dramatically thin. To better understand what is the real value of this therapy and what we have to do to obtain long-term results, you have to imagine 4 different scenarios: the empty alveolus, the grafted alveolus, the single immediate implant without anything, and the single immediate implant grafted. What happens to the fresh extraction sockets without anything? A socket where only the clot will provide the healing of the alveolus. As we can see, many articles have studied this phenomenon. Araujo in 2005, in an animal model, observed that marked dimensional alteration occurred during the first 8 weeks following the extraction of mandibular premolars. Moreover, the reduction of the height of the wall were more pronounced at the buccal than at the lingual aspect of the extraction socket. So, we must understand that if we don't do anything, the alveolus will have dimensional contraction both in vertical and horizontal direction. Second scenario, the grafted alveolus. So, what will happen if we put a biomaterial inside our alveolus? Also in this case, literature can help us. In a paper by Fickle and co-workers, two different techniques of socket preservation were analyzed. In Group 1, bovine bone and collagen. In Group 2, bovine bone, collagen and a tissue graft. Group 3, no treatment, control. The result showed that all groups displayed contour shrinkage at the buccal aspect, but the difference between the two test group and the control group were significant. The conclusion of the authors were that socket preservation techniques were not able to entirely compensate for the alteration after tooth extraction. So, limit but not completely avoid. Third scenario, immediate implant without anything. What's gonna happen if we fill entirely and completely the socket with an implant? Many authors have studied this phenomenon. In 208, Araujo, in an animal model, analyzed the behavior of buccal bone crest in alveoli filled only with an implant. The author concluded that the buccal and the lingual bone walls underwent marked surface resorption, and the height of the thin buccal hard tissue was reduced. On the basis of this result, the complete filling of alveolus with an implant seems not to be the right choice. Fourth scenario, immediate implant plus a graft. What will be the result if we put an implant, creating a graftable gap between the implant surface and the alveolar vestibular bone? Many papers have been published on this topic. In 209, a paper by Araujo analyzed the difference between an immediate implant grafted with collagen and bovine bone versus an immediate implant without any kind of graft. Results show that the buccal bone crest in the test side, the grafted immediate implants, was thicker and located close to the implant border, while the corresponding crest on the control side, without any kind of graft, was thinner. It was concluded that the placement of bovine bone in the void between the implant and the buccal approximal walls modified the process of hard tissue healing, provided additional amounts of hard tissues. In 211, Caneva and co-workers, in the same animal model, used as a test an immediate implants grafted with bovine bone and with a collagen membrane, and as a control site an immediate implants without any kind of graft. As the previous study, the conclusion was that the location of soft tissues at the buccal aspect was more coronal to to the chest, and disease may be related to the level of the heart tissues that was located more coronally. The author concluded that the use of DBBM particles with the application of a collagen membrane contributed to the preservation of the alveolar process. So, on the basis of the literature, it seems reasonable to think that the right choice is to put an immediate implants, leaving a gap that must be grafted with different materials. Very important to stay away in the respect of the prosthetic position of our implants from the critical area represented by the buccal bone. In this way, we obtain a distance from the external surface of our implant and the external surface of vestibular bone. This distance is made by the gap and by the thickness of the bone. As you can see in the picture, different clinical situations can happen, with an increasing risk from left to right. The final consideration are that the right choice is a lingual positioning of our implant, leaving a gap that must be grafted, and never use a bigger implant to fill the gap. Lingual positioning, no bigger implant. Stay away from the danger zone, the dangerous area represented by the vestibular bone. Don't fill the alveolus with a bigger implant. After this biological consideration, let's focus now on surgery. What is the right technique to put in immediate implants? The key points are the extraction, the primary stability, the three-dimensional positioning of the implant, and the provisional prosthesis that we can put on our implant. First, the extraction. It must be automatic. We do not have to stress the vestibular bone, so if needed, you have to separate roots, as shown in the picture. It's very important to separate tooth from the adjacent. In this way, we can use rotational movement that can help us in our extraction without damaging vestibular bone. That I will show is very, very important. After separation, as you can see in the video, we can rotate the tooth and gently extract the tooth. In the same way, it is very important not to damage soft tissues during extraction. Second key point, the primary stability. How can we obtain primary stability? It's very important in the diagnostic phase to evaluate where we can obtain bone anchorage. These are the most common areas where we can obtain it. Apically, on the palatal, very common in the central upper incisors, and the septum in case of molars, and in favorable alveoli, as in premolars. Because we have few millimeters of bone that can guarantee us the primary stability, it's very important the under-drilling of recipient sites. So we must eliminate from conventional procedure 1 or 2 burrs to obtain a correct primary stability. And it's really mandatory, it's very important, the choice of right fixture for this procedure. Not all the fixtures are designed for this kind of therapy. We must use conical fixtures, very aggressive and self-tapping. So we must use them because we have few millimeters of bone that can give us our primary stability. Third key point, three-dimensional positioning. First, what is the right position in the buccolingual direction? As we said, talking about biological consideration, the right position is palatal or lingual, considering prosthesis. So this is the right position of our implant. In this way, as we said, we can leave our gap that can be grafted with different materials. In the paper by Capelli, is identified the correct distance between the external part of the implant and the external part of the vestibular bone. The author concluded that the right distance should be 4 millimeters. So remember, don't forget, stay away from the dangerous area and don't fill completely with the implant. As we previously said, the 4 millimeter distance is made by gap and by the thickness of the bone. So 4 millimeters can be different in different clinical situations. What is the right apical positioning of our implants? The basic rule is to position the margin of the implant 1–2 millimeters under the buccal crest if there are no bone defects on the vestibular crest. Otherwise, you can put 1–2 millimeters under the palatal crest if the vestibular bone crest is damaged, and in this case a GBR must be applied. From a prosthetic point of view, this means that we must put our implant 3–4 millimeters under the planned future gingival margin of the restoration. And what is the right mesiodistal position of an immediate implant? In this case, we follow the general rule of conventional implants. So distance implant to implant 3 millimeters, distance implant to tooth 1.5 millimeters. Of course, we know these spaces are really important because the maintenance of interproximal bone crest are mandatory and fundamental for the maintenance of soft tissues, and so in obtaining an interdental or interimplant papilla. This will change dramatically the aesthetical result of our implant therapy. 4 points. The provisional. In the case of immediate implants, we can both use healing abutment or provisional restoration. If we did not obtain high torque values during the surgical phase, we can use healing abutment. In my practice, I always use low-profile healing abutments. The use of higher healings can be affected by the tongue movement and by the lips movement during phonation, influencing in this way the process of osseointegration. Otherwise, if we obtain high torque of insertion, we can use provisional restoration. Very important, no occlusal loading, both for single tooth or bridges. They should be under-contoured. In this way, we allow the tissue to grow up and always screw retained. This is confirmed by a paper by Dennis Turner and co-workers. Their conclusion: placing a bone graft and a provisional restoration at the time of anterior tooth extraction increases both the vertical and the labia-palatal dimension by between 1/2 and 1 millimeter. So in conclusion, careful extraction is really important. Must be very accurate, very careful, very automatic, don't damage both bone and soft tissues. Evaluate bone anchorage during the diagnostic phase. Use appropriate fixtures, so self-tapping, conical, very aggressive. Under-drill the site. In this phase, the perception of the surgeon of the bone quality is really crucial in obtaining primary stability. Correct two-dimensional positioning. We must be helped by surgical guides that can give us the right position of the prosthesis and of the implant. Graft the gap, and if we have damaged bone crest on the vestibular, please use GBR. At the last, use provisional, but only if we have high torque and always without any occlusal contact. And now I would like to share with you some clinical cases. Case 1. The patient came to my observation in 2014 for a problem on tooth 1.5. This is the vestibular clinical aspect and the lingual aspect. The patient was a female, 48 years old, completely healthy, a former smoker with high functional demands and high aesthetical demands. The analysis of tooth 1.5 showed us a deep fracture on the palatal aspect. We evaluate different therapies. Crown lengthening was excluded for a too short rod length, and orthodontic extrusion excluded for the same reason. A Maryland bridge and a conventional bridge were excluded by the patient. So our choice was an immediate implant. This is the planar therapy, an hygienic phase, extraction, an immediate implant, and a definitive crown. The analysis of the bone showed us that we have enough bone to obtain our primary stability. We made the extraction very gently, without damage to the residual vestibular bone crest. After a complete check and probing of the residual bone crest, we prepared the site for implant positioning. We put the implant and then we graft the residual gap between implant and vestibular bone crest. To transfer the implant position to our dental technician, we use a precasted resin jig on which we blocked the impression coping with red resin. The provisional was prepared by the dental technician and then we screwed to the implant. In the picture you can see the moment of the delivery of the provisional. The healing went on until 6 months. At 6 months you can see the good aspect of soft tissues, and the X-ray shows us the good osseointegration of our implant. Soft tissues seems to be very healthy. As we can see, we have maintained the level of the gingival margin. A new conventional impression was taken. An abutment was prepared and a definitive crown was delivered to the patient. As we can see, we maintain the level of the gingiva. This image shows the pre-extraction, the provisional phase, and the definitive crown. At 1 year, we can see the good aspect of the crown and the good X-ray aspect of the implant. Case 2. The patient, female, 45 years old, non-smoker, comes to my observation for a problem on a tooth 2.1. The patient had frequent abscesses on the element, and X-rays showed us an internal root resorption. The patient requests never without a tooth, no provisional removal dentures, and no conventional prosthesis. In the case of aesthetics, it's very important to evaluate the smile line. In our case, was high. The bone analysis showed us that we had sufficient bone for primary stability, and the interproximal bone crests were maintained. But we have a thin gingiva and definitely unfavorable gingival margin. We decide to plan an immediate implant with immediate provisional with no occlusal loading, and then a definitive screw-retained zirconia crown. Also in this case, a very careful extraction separating the tooth from the adjacent, and then we rotate and very carefully extract the root. We made a bone probing and then a side drilling to prepare the site for the implant. After implant positioning, we can see the great gap that resulted from the position of our implant, and then we graft it with bovine bone and collagen. As we can see, this is a high-risk clinical situation. We prepared a chairside immediate provisional that was immediately delivered to the patient. After 6 months of healing, we can see the good result in terms of stability of soft tissues. Then we performed an impression using a customized impression copying. In this way, we can transfer to our dental technician not only the position of the implant, but the shape of the mucosal channel of our implant. After a few days, a definitive crown was delivered to the patient. Here we can see the pre-op and 1-year control of the crown. Case 3. The patient, a male, 20 years old, completely healthy and not smoker, came to my observation for a problem of tooth 1.1. The tooth looked at discoloration, mobility. In the anamnesis, the patient told me that the tooth was traumatically extracted at 10 years and then reimplanted after root canal treatment. X-ray showed us the infection and the apex of the resorbed root. So what was my decision-making process to decide the right treatment? Our tissues. We have sufficient amount in height. The interproximal bone crests are well maintained. The CT scan showed us the volumes. As we can see, we had good bone volumes for primary stability. And this should be the position of the implant. But as we can see, there are some facial bone missing due to the infection. So, GBR is required, and we could not have a flapless approach. Soft tissue evaluation. A thick gingival biotype. The gingival level on tooth 1.1 was extremely favorable. The amount of keratinized tissue was favorable too. So, on the basis of my analysis, the choice was an immediate implant, a GBR, and a screw retain provisional with aesthetic function. The flap design I have planned a full thickness mucoperiosteal flap involving 2 adjacent teeth, and vertical incision is required, not in the gingival zenith. We raise the flap and then we extract the tooth. After a toilet of the lesion, we can see the residual bone. After probing, we prepare the site for the implant and then we position the implant. A GBR procedure was performed using bovine bone and a collagen membrane. The flap was sutured. Also in this case, a chairside provisional restoration was immediately delivered to the patient. After 6 months, we can see the good healing of soft tissues. Then, a definitive screw-retained crown was delivered to the patient. As we can see, after 1 year, the good integration between the crown and the soft tissues. Thank you very much for your attention.